Hi everyone, this is Tim, your Block 3 lecturer instructor, and today's PowerPoint voiceover is going to be on gastrointestinal diseases, specifically GERD, hiatal hernia, and peptic ulcers. This is actually fairly short. I broke up the entire GI lectures into smaller ones, so they're just easier to digest. Anyway, so like I said, it's pretty simple. It's probably more the GI problems are probably more prevention and interventions than anything else. So, all right, so the upper GI tract starts with the esophagus and it goes all the way to the stomach. And the first disease process is going to be GERD, which is gastroesophageal reflux disease. It is the backflow of gastric or duodenal contents into the esophagus. This is caused by an incompetent lower esophageal sphincter, pyloric stenosis, or motility disorder. GERD's probably most commonly caused by the lower esophageal sphincter. This is where the esophagus and the stomach meet, and that sphincter doesn't always completely close correctly. So because of that, that's where the either the contents is actually backflowing, or let's call it, for lack of a better term, fumes from the gastric juices themselves are actually kind of creeping up into the esophagus. So assessment-wise, you're going to look for heartburn, epigastric pain. The epigastric pain is probably going to be caused more from the gas, the acid itself, because it is very acidic. It doesn't always stay in the stomach, and when it comes up through the esophagus, that's where it's actually starting to corrode and eat away at the esophagus. You're going to have dyspepsia. You're going to have regurgitation, which is the backflow. You're also going to have difficulty or painful swallowing, and this is probably more of a symptom from the burning of the acid itself. And then you're also going to have hypersalivation. The hypersalivation is probably more from you trying to continuously swallow to be able to keep those gastric juices into the stomach and to keep it from backflowing up and actually causing harm to the esophagus. Interventions, you're going to avoid foods that cause esophageal irritation, such as peppermint, chocolate, coffee, alcohol, fried fatty foods, and cigarette smoking. You're also going to eat a low-fat, high-fiber diet. You're going to avoid eating or drinking 2 hours before bed. I think this is because of the fact that, by you eating and drinking, your body is producing more gastric juices in order to be able to break stuff down. So if it's breaking stuff down before you go to bed, and because of the fact that we all lay flat, it doesn't allow the juices or the gastric acid to stay into the stomach itself. This is why you elevate the head of the bed 6 to 8 inches. I had read somewhere that you can actually, instead of raising the entire bed 6 to 8 inches, you're actually raising the head of the bed by putting blocks or bricks or something to be able to raise, just like I said, the head, and it's more of a slant. And at first I thought that was kind of odd because then you'd be sleeping at a slant. But this actually does work. So, again, don't eat or drink before bed so that way your stomach has a chance to actually calm down and not produce more. You also can elevate the head of the bed because by sitting up higher, the juices or the gastric acid stays in the stomach. You're also going to avoid NSAIDs because that also is a very big irritant of the stomach, and it also causes more acid to be able to break it down. Other interventions is taking antacids, H2 receptor antagonists, or proton pump inhibitors. This is either going to reduce the amount of acid in your stomach that's already existing, or it actually will help stop the stomach from producing so much acid, and that's what the two inhibitors and antagonists do. Worst case scenario, you can also do surgery. I think the surgery is going to be more on that sphincter, as far as either, I don't think they can replace it, but I think they probably will do some sort of suturing to make it close a little bit better. All right, so the first drug is going to be the antacids. They work by counteracting or neutralizing the acid in your stomach. They do this because the chemicals in antacids are bases, which are the opposite of acids. A reaction between an acid and a base is called neutralization. So basically, you take an antacid and it breaks down the actual acid in your stomach. This neutralization makes the stomach contents less corrosive, and this can help to relieve the pain associated with ulcers and the burning sensation as acid reflux. They also have magnesium-containing acids, which tend to be more of a laxative, whereas aluminum-containing antacids tend to be more constipating. So you can get antacids that are aluminum-based or magnesium-based. They both antacids may balance out the effects of the gastric content itself, and this also minimizes the side effects of diarrhea or constipation. Histamine or H2 antagonists. H2 blockers are a group of medicines that reduce the amount of acid produced by the cells in the lining of the stomach. Most common histamine or H2 antagonist is famotidine or ranitidine. Those you actually can find over the counter. With proton pump inhibitors, or what we also call PPIs. This reduces the production of acid by blocking the enzyme in the wall of the stomach that produces acid. They're also longer lasting. You either can take them every 12 hours or every 24. They are usually over the counter. The only one that's probably not is Protonix. That's something that's actually prescribed, but Meprazole, the Nexium, the Prevacid, those three are over the counter, and I actually take the Prilosec every day. And based on what I've eaten and how much soda I've drank for the day, I might actually have to take more in the afternoon or evening. So, all right, so the next disease process for the GI tract is the hiatal hernia. A portion of the stomach herniates through the diaphragm and into the thorax. Aggravating factors can be either pregnancy, ascites, which is usually a engorging of blood vessels in your esophagus, usually caused by alcohol or high blood pressure, and also obesity can also be an aggravating factor to this, or tumors and heavy lifting. Complications of a hiatal hernia can be ulceration, hemorrhage, regurgitation, or aspiration of stomach contents. So here's a picture of the hiatal hernia. You can see on the left-hand side is a normal stomach with the esophagus meeting the, where the esophagus and the stomach meet. And the line that's kind of going across is the diaphragm. And on the right side is where the actual outpouching is and where the hernia has been made. Assessment-wise, you're going to find your patients are going to have heartburn, regurgitation, or vomiting, because a lot of times that either stomach acid or food that has been chewed and swallowed and in the process of being broken down can actually collect in that hernia. You're also going to have dysphagia, or you're going to have the feeling of being full. Interventions are going to be take antacids, H2 receptor antagonist, or PPIs, and this is to actually help reduce the amount of acid so that way it doesn't collect in that hernia, and then which will then cause more erosion or problems to the esophagus. Other interventions are going to be surgery. You want your patients to actually have small, frequent meals instead of large ones, because if you sit down and eat this huge, large meal, you're more likely to get food trapped in the hernia. Small, frequent meals are probably going to be easier to chew and digest and go away quickly. You're also going to limit the amount of liquids taken with meals. We tend to eat our food and drink at the same time, and that will cause this to actually back up. Do not recline for 1 hour after eating, because again, you're really wanting to sit straight up. You want food to be able to, based on gravity, go from you chewing it, you swallowing it, and it actually staying in your stomach. You're also going to avoid anticholinergics, which delay the stomach emptying. It might be the last disease process is peptic ulcers. The stomach normally produces acid to help with digestion of food and to kill germs such as bacteria. This acid is corrosive, so your body produces a natural mucus barrier which protects the lining of the stomach from being worn away. In some people, this barrier may have broken down, allowing the acid to damage the stomach, causing an ulcer. The most common are gastric or duodenal ulcers. Here's a picture of the stomach and the gastric mucosa, and then again, based on either eating, drinking, disease process, I mean, whatever have you will cause the mucosa to break down. And once it's broken down, the acid itself is so erosive and so acidic that it actually causes to burn holes in your stomach. Other causes can be stress, which will cause more gastric content or more acid to be produced. It also could be smoking because it's a vasoconstrictor. We've got corticosteroids, we've got NSAIDs, we got alcohol, we got family history or infection, which is H. pylori. Assessment-wise, for the gastric ulcer, it's going to be a gnawing, sharp pain in or left of the mid-epigastric region. It occurs 30 to 60 minutes after a meal, and hematemesis is more common than melena. So basically what happens is that you eat food. While you're eating food and your body's trying to digest, it's going to cause more acid to be produced. And because of that, that's what's actually causing the irritation of the already existing ulcer. So that's where you get the gnawing, sharp pain in the epigastric region. With a duodenal ulcer, you have burning pain in the mid-epigastric area. This occurs 1.5 to 3 hours after a meal and during the night. Melena is more common, and pain is often relieved by the ingestion of food. The way this works is you have to figure out where the duodenal intestine is. Because of that, you know it's going to be the mid-epigastric area. Because of where it is and because of the slower process of breaking food down, that's why it takes 1.5 to 3 hours after the meal to actually cause the burning pain. Pain is relieved by more ingestion of food, and they think that's because of it actually kind of coating the stomach itself and in the process of being broken down. Interventions are going to be monitor vital signs for bleeding, small frequent bland meals, anything that's too large and too much and too spicy is going to irritate that ulcer. Administer H2 receptor antagonists or PPIs. Administer antacids to neutralize the gastric secretions, administer mucosal barrier such as saccharofate. And the reason why I say no this medication is because this is actually very common for patients who have ulcers, whether it be gastric or duodenal. What it does is you actually take it, it breaks down, it actually goes straight to the ulcer and coats it, so it actually almost like a band-aid for it. And then when you eat and more gastric juices are produced, it's actually not irritating the ulcer and it gives it a chance to actually heal. You tend to take it 3 times a day, breakfast, lunch, and dinner. Again, you have to take it about an hour before you eat. So I don't think people are necessarily non-compliant for taking it. I mean, because who wants to be in pain from an ulcer? But I also think it's a matter of, no one really has an hour of, okay, well, I'm going to take this pill, I'm going to eat an hour, and then it's going to work. I think it's more of a, oh, we're going to be eating now, and you try to take it, it didn't really have time to do its job, and next thing you know, it didn't really work. You can also administer prostaglandins, which will also help. So for patient education, avoid consuming spicy foods, avoid smoking, avoid NSAIDs, sleep well and avoid stress. I think these are pretty easy to do in order to either relieve the problem of an ulcer, because the ulcers can really go away once they've actually been healed. But again, it's hard for people to stick to a certain diet, and people who smoke, it's hard for them to quit, and some people who are having the need of pain medication or NSAIDs, again, it's not a matter of they don't want it to work or don't want it to heal. It's just a matter of whether or not they can avoid the other things in order for it to happen. All right, so I think this might be the last one. So GI bleed, gastrointestinal bleeding, also known as gastrointestinal hemorrhage, is all forms of bleeding in the gastrointestinal tract from the mouth to the rectum. When there is significant blood loss or over a short time period, symptoms may include vomiting red blood, vomiting black stools, or bloody stools, or black stools. I'm not sure why I kept saying black. But I will tell you that the easiest way to remember this is that if you're bleeding somewhere from your mouth to your rectum, based on where it comes out is probably the closest point as far as where it's bleeding. So let's say that I get nauseous, I throw up, and it's bright red blood, then we know that it went from stomach to esophagus to your mouth. If it is tarry, most likely it's actually coagulated blood, which means that it's actually further in the GI tract. So if you have a bowel movement and your stools are very black and tarry, it's because of the fact that you're bleeding probably from the small intestines up, and by the time it actually got to the point where it's coming out, it's been coagulated, and that's what makes it black and tarry. That's the easiest way for me to remember it. So interventions during active bleeding, you're going to monitor vital signs for shock. You're going to make sure that your NPO is, you're going to make sure that your patient is NPO, and you're also pushing IV fluids to keep them hydrated. The NPO is to make sure that either two things. One, they're either going to either have a colonoscopy, a EGD, or some sort of surgery, or you actually, if they're having a GI bleed and it's actually in the stomach or the esophagus, you don't want to continuously feed them food because it's going to continuously cause more gastric juices to be produced, and that's either an ulcer is going to be aggravated, or they're having something in their esophagus that's also aggravating, and you just don't want to add more food to it. You're monitoring eyes and nose, especially for GI bleeds, whether they're having large, bloody stools or diarrhea, or whether they're having black tarry stools in this diarrhea. You want to be able to make sure that what is coming out is actually being replaced by IV fluids, because if not, you are going to start getting that shock. You're going to monitor H&H, which is the hematocrit and the hemoglobin, because if they're having a GI bleed, if it's very fast, you're going to see a drop very fast. Usually they'll do blood draws for H&H either every 6 to 8 hours, or they'll do them every 12 hours, or they could possibly do them every 24. And it's based on how slow it is, because you can also have a very slow GI bleed, and that will take a long time for the H&H to drop. I've actually had patients who come in throwing up blood or having bloody stools, and we admit them, and then they don't have another bowel movement, and we have no idea where the bleed is. So it's kind of a catch-22, I guess. If the H&H is low enough, usually if it's less than 7, or if it's based on how fast they're bleeding, they'll actually do a blood transfusion. So let's see here. Here is your EGD. It's also called an esophagogastroduodenoscopy. Basically, they're going to stick a tube down your throat, into your stomach, look around, and then they actually can go past the stomach into the duodenum. And again, they're looking for either ulcers, they're looking for tears, perforations. I mean, they're looking for something. They also can actually see where there's bleeds. Let's see here. The first picture on the left is the capsule endoscopy. I've actually had patients who have done this, and it's actually pretty cool. So they swallow this little pill, and it basically takes pictures all the way from the time that they swallowed it until the time it comes out. And then on the far right is the scope for the EGD. And again, they're looking for gastric ulcers or some sort of bleeding or other problems. That's it. So if you have any questions, let me know, and you can move on to the next PowerPoint, which I think is probably lower GI. If you have any questions, let me know.